with blood pressure.
Can we start, man?
Yes, please start.
Yeah, okay. So, guys, can you just uh, turn off your mics? If you can, it will be very helpful. Thank you. So, good evening, all. My name is Dr. Kushal. As Madam is our all guru, everybody's guru. She is my guru as well. So, I've been learning from her since almost, let's say, 10 years now, five to at least 7 years to 10 years now. So she has been a motivating factor for all of us, you know. So, this madam has given me an opportunity to present to you uh, regarding the spectrum of glycemic control. So what we are going to do today is uh, we are going to speak on hypoglycemia and severe decay, both side of the spectrum. Um, to start with hypoglycemia, we all know what is hypoglycemia. Hypoglycemia is low sugars, low glucose. Uh, Multiple debates have been there throughout generations as to how to define hypoglycemia. Okay, and some have definitions as to based on the signs and symptoms of hypoglycemia. Some have defined biochemically biochemically on value of glucose of hypoglycemia, and I am sure the debate will be going on and on. But for exam purpose, um, we have to write hypoglycemia is defined as plasma glucose concentration below 70 mg per dl. So low sugars with signs and symptoms of hypoglycemia, okay, which will be discussed on the later slides. And the third part is the reversibility of those symptoms of hypoglycemia on glucose administration. So this is an important definition. It consists of triad. As I mentioned, low sugars, signs and symptoms of hypoglycemia, and reversibility of symptoms on glucose administration. Uh, this is a triad. So why this confusion arises? Because whenever a patient comes to you with low glucose, in not in a proper GCS state, you always check capillary glucose levels. What the studies have found out that the capillary glucose level is approximately 15 times lower than the venous sample what they collect. So that's why some will not have some will not have symptoms even at 60 mg per dl, but some may have symptoms at 70 mg per dl because they check capillary glucose. Okay, so sorry, they check venous samples and not capillary glucose during that time. So that is why the debate was there. Okay, coming to the main cause among the patients of diabetes. Type 1 diabetes tends to have a higher incidence of severe hypoglycemia, ranging the incidence from 3.3 to 13.5%. Why this is seen? Because what happens in Western countries where the most studies goes on, what they do is they thought that to prevent the diabetic microvascular and macrovascular complications like stroke and heart attack, we should have a better glycemic control. So in order to do that better glycemic control, higher patients went into those hypoglycemia. So one of the very famous study they have done is United Kingdom prospective diabetic study, which is called as UKPDS. What they have found out is when they started controlling the sugars, like they controlled sugars below HbA1c 7, they saw higher hypoglycemic episodes. So that's why United Kingdom always supports to keep the HbA1c between 6.5 and 7 and not below 6.5, because those patients tends to have a higher hypoglycemic episodes. Even a study called as diabetic control and complication trial also found out that 1 in 60, every patient in every patient with 65% of type 1 diabetic patients had one episode of hypoglycemic episode in their life when while going the trial. How do you classify hypoglycemia? So, as we all know, there are three levels of hypoglycemia: level 1, level 2, level 3. Level 1 is when the sugars are below 70, but not below 54. So, somewhere between 70 and 54 is your type 1 or level 1 hypoglycemia. This patient constitutes mainly autonomic dysfunction. Some will have anxiety, sweating, restlessness, and all that, but will not have any neuroglycopenic symptoms. These patients can be managed on OPD basis with simple oral glucose to be given. Level 2 Level 2 hypoglycemia is defined as when the glucose concentration falls below 54 mg per dl, which requires immediate attention and immediate correction of the hypoglycemia. And level 3 defines not on a particular number of glucose, but defines on the mental capacity of the patient. So whenever a mentation or the CNS function is distorted or impaired, the patient automatically falls into level 3 hypoglycemia, and this requires an external intervention which requires immediate correction of this hypoglycemia to provide further complication. Coming to pathogenesis, so what happens in hypoglycemia is whenever there is an hypoglycemia, there is reduction in insulin levels. This reduction in insulin levels will cause counter-regulatory hormones of insulin, counter-regulatory products of insulin like glucagon, epinephrine, cortisol, growth hormone to increase. Okay, so once this counter-regulatory components are increased, what this will do is it will increase glucose and decrease insulin sensitivity in the body, finally leading to increased glucose in the body. Okay, so there are various mechanisms it does is like cortisol will increase gluconeogenesis, glucagon will increase hepatic glucose output, epinephrine will cause decrease insulin in the body, will cause increase lipolysis, that is increase free fatty acid generation in the body. Okay, growth hormone will decrease the insulin sensitivity. So the finally what happens is all this will cause increase in glucose level in the body. Uh, what are the risk factors of uh, of patients going into hypoglycemia? One of the most common risk factors, what studies have shown, is the use of oral hypoglycemic agents, especially the older generation oral hypoglycemic agents which are long acting, like sulfonylureas, glenites, thiolinidazones. They are very long acting. It works for approximately 48 to 72 hours. And this drugs are the main reason for hypoglycemia in diabetic patient. The one of other reason is patients who are diabetic and who has a chronic kidney disease tends to have a higher episodes of hypoglycemia than if you compare the patient with diabetic without chronic kidney disease. Why is this? Because there is in a CKD patient, what happens is there is decreased renal clearance of insulin, and there is a reduced renal gluconeogenesis. These are the two main reasons why a patient will require low insulin in a CKD rather than a patient with diabetic without a CKD component. Okay, so if you prescribe 10 units of insulin for a CKD, for a non-CKD patient, you have to taper it down to 8 or 6 in a patient with CKD because of reduced renal clearance of insulin. The third risk factor is elderly. Again, coming to the same point, elderly will have slight deterioration in renal function affecting drug clearance. Also, elderly patient might have a lot of other comorbidities for which he or she must be taking a lot of other drugs. So polypharmacy itself can cause adverse reaction because of various interactions between the drugs. And of course, decreased cognitive function. There is a possibility that elderly patient might forget that he or she has taken an OHA and might take again, and this will lead to a hypoglycemic episode. Coming to precipitating factors, so like any other any other glucose emergency, hypoglycemia also has precipitating factors. So whenever a patient comes to you with hypoglycemia, you not only have to treat the hypoglycemia, but you have to look for the precipitating factors as well. In this case, hypoglycemia, most common reason is OHA or higher insulin doses without adequate intake of food, without adequate intake of carbohydrates or food. Okay. Second most common reason is in a critical ill patient who are having sepsis or having any cardiac or renal failure. Uh, Addison's can act as a precipitating factor for hypoglycemia, or cortisol insufficiency can act as a precipitating factor for hypoglycemia. Endogenous hyperinsulinism, that is insulinoma, other pancreatic tumors, uh, post surgery, that is post gastric bypass surgeries, can have hypoglycemia because of decreased absorptions of carbohydrates. Okay, this all, the list is long, but anything you have to search, and any patient comes with hypoglycemia, you have to search for precipitating factors. Like we had one patient who had come to us, a young guy who came to us, our ER, with the hypoglycemia. Um, and we treated with 50 with dextrose as according to the protocol. uh, Usually what happens, hypoglycemia gets treated, and the recurrent hypoglycemia is very uncommon in ER since the patient is already on dextrose. But what happened to this particular patient is, this patient, instead of giving 50D or 50% dextrose, this patient continued to have the episodes of hypoglycemia in the ER. So we gave approximately 3 to 4 such 100 ml of 50D, and still patient had a hypoglycemia episode and a seizure in ER. So this is what warrant us to find what is going on, and that's how we got some scans done, including an abdominal scan done, and this young patient was found out to have an insulinoma. And when we send a C-peptide level to, which is a diagnostic criteria for, which is a lab diagnostic criteria for insulinoma, it came positive. So, we are very happy that we could find something which is very rare in ER. Okay, so always look for the precipitating factors, very important. Okay. Coming to the signs and symptoms, they are mainly divided into two. That is, one is called as an autonomic, one is called as neuroglycopenic. So autonomic, as the name suggests, it is an autonomic dysfunction. Symptoms like anxiety, tremors, palpitations, paresthesia, sensation of hunger, restlessness. All this symptoms present to us, when the sugars are below 70 and patient is still conscious. Once the sugar level falls to 50, then something called as neuroglycopenic, when the CNS system is involved, that particular symptoms arise, like lack of concentration, headache, loss of consciousness, speech disturbance, convulsion, confusion, blurred vision. So neuroglycopenic is the patient comes to you with low loss of consciousness or altered sensorium. Itself means that patient's sugar levels are critically low, and it automatically falls, as I told you before, in the level 3 category of hypoglycemia, and which requires an immediate treatment. Okay. Coming to differential diagnosis, the list is endless. Consists of stroke. So any neuroglycopenic where the patient has come to us with altered sensorium, we do have to correct the sugars. But if the sugars are even after correction, patient has deficits, you have to think of differential diagnosis like stroke, which can act as a trigger to hypoglycemia, a TIA episode, a seizure episode, a traumatic injury, psychosis. We had one patient who, hello, uh, can you turn off your mic, please? Yeah. So we had one patient who got hold of an amphetamine uh, in Bangalore, and he took some amphetamine. He came with a high. He came very high to us, like enjoying his life in euphoria state to us, and suddenly he had a seizure, and we came to know that he had an hypoglycemia. When we corrected his glucose and he was normal, he told us the history that he got an amphetamine. So sympathomimetic drug injection can have a hypoglycemic episode, especially in cosmopolitan cities where it is easily available. Coming to restation. So whenever a patient comes to you with hypoglycemia, whenever there is a neuroglycopenic symptoms predominant in those patients, you always have to make sure your restation starts from airway, breathing, circulation. That is a mainstay. Make sure the airway is clear, adequate suctioning is done. In case he's not able to maintain an airway, try to avoid intubation, because you within few minutes, as you give glucose, he will come back to normal state. So in case he's not maintaining his airway, you can put an OPA and try to oxygenate as much as possible, and while you are giving a correction of glucose. Okay, breathing, give an oxygen, make sure the saturation is maintained above 94%. In circulation, you put a large bowl cannula, 18 gauge, if it is possible, so that you can correct the sugars rapidly. Okay. So how do you correct? If at all the patient has only autonomic symptoms, and you see patient is conscious, patient is talking to you, and the sugars are on the lower side, you can give an oral carbohydrate, oral glucose solutions to increase the sugars. In patient who are having an altered mental status, the guideline says that it is always better to give 50% dextrose, that is 100 ml, 50% dextrose IV, or a bolus of 50 ml is preferred. That is roughly equates to 25 grams of glucose. And this dose is repeated if the hypoglycemia persists. Post correction, post the patient is conscious, you have to make sure that you keep the sugar level above 100 mg per dl at any point. So in order to maintain that, it is always an individual protocol, but what we do is we continue 10% dextrose at 10 ml per hour until we find the precipitating factors why this has happened. Okay, blood glucose is checked every 30 minutes once the sugars are corrected. Okay, for the first 2 hours. In case patient has a history of sulfonylurea overdose, high hemodialysis has been mentioned in certain case report. But again, it's not, I have not seen anybody performing hemodialysis for a sulfonylurea overdose. It is always the glucose correction that works. Coming to the other treatment, apart from glucose, octreotide is a somatostatin analog, which is used to suppress the insulin secretion. So what happens is in sulfonylurea, this is mainly used in sulfonylurea-induced hypoglycemia. So how sulfonylurea works is it is kind of sulfonylureas are insulin secretagogues. So what they mean is it will modulate the pancreatic beta cells to stimulate insulin. Octreotide, what they will do is this stimulation of insulin will be suppressed by this octreotide, which is also a somatostatin analog. Okay, so it is specifically used in sulfonylurea induced hypoglycemia. Again, it is not the first line of treatment. Even if the patient comes to you with sulfonylurea induced hypoglycemia, it is always recommended to give initial glucose therapy. In case after the initial glucose therapy, patients again go to rebound hypoglycemia, then we prefer to give octreotide. How much it is given? It is recommended to have 50 to 100 microgram sub-Q injection. And in case recurrent hypoglycemia occurs even after this injection, we can give one more bolus, or we can give the same 50 to 100 microgram every 6 to 8 hourly. Okay. So again, this is not the first line of treatment. Glucose is the first line of treatment. It is only given after the first episode gets corrected and the patient goes to rebound hypoglycemia. Okay. Coming to glucagon, it is again an FDA approved alternative treatment. So in case the patient is not responding to glucose therapy, we can try glucagon, but it is not as effective as dextrose. Again, it will take long time to act. Literature roughly tells that it takes around 10 minutes for the normalization of mental status. How do we give? We give 1 gram sub-Q or IM injection. Okay. And what they say is one injection, 1 mg of glucagon increases glucose to around 100 mg per DL. So coming to end of hypoglycemia, do you have any doubts on this? Can I move to the next topic? Any doubts in this? Understood, guys? Can I move?
Yes, sir.
Okay. So coming to the other part of the spectrum, that is severe decay. So I think so. I have taken a session before for decay. What I'm going to do today is only severe decay. As we all know, diabetic ketoacidosis is a life-threatening metabolic complication of diabetes. It results from either an absolute deficiency of insulin or a relative deficiency of insulin. What happens in decay is whenever there is a deficiency of insulin, wherein there is a decrease in insulin levels, the counter-regulatory hormones, that is again glucagon, cortisol, catecholamines, increases in the body, which will finally uh, increase the glucose level in the body by various mechanisms. This increase in glucose will cause hyperglycemia in the body. Hyperglycemia will have a lot of effect. One of the effect is osmotic diuresis. So patient will have a lot of diuresis causing dehydration and finally hypovolemia. Again, apart from glucose, fat level lipolysis also will take a role in this. So whenever there is increase in catecholamines, there is an increase in lipolysis in the body, which will cause increased free fatty acid. This free fatty acid is converted to ketones, and hence this leads to acidosis. So this all what I've explained you will lead to something which is called as a triad of decay: acidosis, low bicarbonate levels, and ketones positive. If you go a step forward, if the patient still worsens from this point, the anion gap increases there and the serum osmolarity level of the blood increases, which will lead to altered mental status. Okay, and this altered mental status, along with the pH of less than 7, bicarbonate level of less than 10, anion gap of more than 12, and ketones positive, is something called as severe DKA. Okay. Most of the cases, 50% of the cases in diabetic patient who presents to us with severe DKA, there is an infection, there is a trigger point which has lead to this state, and that is an infection. Okay. So what they have noticed is, as we discussed in hypoglycemia, that there is a trigger point, there is a precipitating factors. The same thing is true for this hypoglycemia as DKA as well. Infection results in 30 to 50% of all DKA patients. And most common of this infection is either a UTI or a pneumonia. Either it is E. coli or Klebsiella. Okay, very common organisms to cause this. Okay, the other causes are non-compliant with diabetic medications, a stroke, sometimes overuse of alcohol, pulmonary embolism, or acute MI or ACS can also present as a precipitating factor for decay. So whenever a patient comes to you with decay, always you start treating the decay, but always start, at the back of the mind, always work up for precipitating factors to why it has happened. Coming to signs and symptoms, the list is huge, but it can present with polyuria, polydipsia, weight loss, abdominal pain. Metabolic acidosis tends to cause this abdominal pain. Okay. Uh, Severe decay, especially, will have signs of dehydration and hypovolemia, like loss of skin turgor, dry mucous membrane, tachycardia, hypotension. Okay, this acidosis that is built up in the body, that is a metabolic acidosis, will have a compensation by the body, which is called as osmosis respiration, irregular respiration. Okay. Altered mental status is seen in decay when the serum osmolality is more than 340 millimoles per liter. Okay. So this change in osmolality is something, we should be worried about, especially during the treatment as well. I'll discuss that when we come to that. Uh, Investigations, how do you investigate? You kind of starts, whenever a patient comes to you with DK, you investigate, you do a quick, take a line, do a quick ABG, VBG, whatever you get hands on. Okay. You will see metabolic acidosis for sure in DK, uh, plus minus respiratory component in case if it is not that acute. But if it is acute decay, you will not see any respiratory component. Okay. Respiratory compensation, sorry. Blood picture, when you do a complete blood picture, you will find leukocytosis, or if it is a viral etiology, you might find leukopenia as well. If you look for electrolytes, there will be low sodium because hyperglycemia tends to have a low sodium. So you always have to calculate the corrected sodium when a patient, you are dealing with a hyperglycemic patient. Okay. Potassium will be high, can be low based on, the patient's presentation. Most of the cases, diabetic ketoacidosis will have a higher potassium level. Okay, which anyhow you are treating it with insulin infusion. If there is a potassium imbalance, there is a magnesium imbalance for sure. So always look for magnesium and other electrolytes also when you are investigating for a decay. Blood ketones, if you don't have a blood ketone strip, urine ketones is also fine. But if you have blood ketones, very good, very well, you will have a quick test, quick results. Okay. ECG, you have to work up for the precipitating factors. So ECG comes in your primary survey itself. So you get a ECG, look for any abnormalities, especially an ACS or an NSTEMI, a STEMI or an NSTEMI. Okay. Meanwhile, you can also look for signs of hypokalemia, hyperkalemia until your electrolyte results come. X-ray, if you are thinking of an infection because of infection as a precipitating factors, always get an X-ray done to look for any consolidation, and abdomen for an abdominal sepsis or an abdominal infection to rule out. Yeah. So initial resuscitation treatment, always, as I mentioned in ER, the treatment starts with airway, breathing, circulation. In airway, always maintain the airway. Uh, might, in a severe decay with severe maintenance problems, might require intubation. But if the airway is maintained and if the saturation is good, just put an oxygen and try to avoid intubation in case you feel you are confident enough to treat the patient. But again, it's entirely up to your discretion. Circulation, put a two wide bore cannulas, uh, two wide bore cannulas, 18 gauge for the restation. Meanwhile, when you're doing your ABC check, always make sure you do a screening echo. Just make sure that patient has a good EF, because you're going to give a lot of hydration to the patient. So do a screening echo, look for EF, look for IVC, and if the IVC is full, you can change your aggressive hydration levels as well. So how do you restate, how do you give the hydration? So what they say is, in a patient with diabetic ketoacidosis, the fluid deficit is around 10 to 15% of the whole body weight. So you have to correct that 10 to 15% of fluid deficit. How do you do that? You start hydrating with a normal crystalloid. There have been long debate for 50 years that what is the crystalloid, what is the fluid of choice, whether it is crystalloid or colloid. But multiple studies have been done and no conclusive proof has been out. So what they say is normal saline is best for resuscitation fluid, especially when the patient is hypovolemic in severe decay. Okay, so start normal saline at around 1 liter per hour for the first 4 hours. Uh, why this immediate resuscitation is important? Because it not only corrects the hypovolemia, it also restores the tissue perfusion and helps in getting the hyperglycemia in control, and also helps in clearing this ketones out of the body well. Okay. So, how do you treat in a young patient who has a good EF, IVC collapsed? So, you hydrate at around 1 liter per hour for the first 4 hours. There are studies that has compared a higher level of or aggressive hydration with a normal hydration. So, no much response has been, no much conclusive proof is there of uh, what is the liter per hour hydration is better. But in patient with hypoglycemia, hypovolemia, it is always better to hydrate at a faster rate to maintain the perfusion. If the BP is stable, if the blood pressure is stable and patient is not having any hypotension, hydration of even 500 ml per hour for the first 4 hours is adequate, what they say. Okay. But for exam level, you can, for the exam purpose, you can tell aggressive hydration of 1 liter per hour for the first 4 hours. Coming to the maintenance, it depends on your hospital protocol. But what they say is, a balanced solution like an RL is always preferred over NS. But again, it depends on. Sorry. Okay. Okay. So, as I told, maintenance depends on your hospital protocol where you're working. But your choice when you're doing a maintenance fluid replacement, your choice should depend on four main things. The fluid should maintain the hemodynamics, should maintain the state of hydration, should make sure that serum electrolyte levels are maintained in normal limits, and urine output is normal. Okay. If you are giving a normal saline, sometimes patients tends to have this hyperchloremic acidosis, which is a major concern as you are hydrating at an aggressive level in such kind of in severe decay. So in such cases, you can switch to ringal lactate or a balanced solution as a maintenance fluid. Okay. Coming to insulin, insulin is the mainstay of treatment. You do understand that insulin is not only to reduce the sugar levels or the glucose level in the body, but insulin is the mainstay to clear the ketones, which is the main problem in diabetic ketoacidosis. Okay. So you start the insulin at 0.1 international unit per kg, zero point 0.1 international unit per kg per hour. So what books used to say is always give an initial bolus of zero point 0.1 international unit per kg, but the recent studies have shown that the bolus of zero point 0.1 international unit per kg, what we give before the start of the infusion, doesn't help in the overall mortality or morbidity of the patient. Okay, and also this bolus will cause a greater chance of hypoglycemia in such kind of patients. So now what they do is they prefer directly to start an infusion of zero point 0.1 international unit per kg per hour. Okay, so as I mentioned, this treatment is not to reduce the glucose level, but to clear off the ketones from the body, which is causing the acidosis. Okay, so until the ketones are positive in the body, we have to continue this infusion. So when you are starting an infusion, you are keeping the patient in ER for a few hours. There is a possibility that the plasma glucose level reaches around 250 mg per dl, and this is where you start an dextrose containing solution along with an insulin infusion that is reduced to a half a rate, that is 0.05 international unit per kg per hour. So again, I'll tell you, we start the insulin infusion at zero point 0.1 international unit per kg per hour. So in a 60 kg patient, we start at 6 ml per kg per hour of insulin. Okay. Once the sugar is reached to 250 mg per dl, this insulin is turned to half. So 6 ml per hour is reduced to 3 ml per hour, along with a dextrose containing solution like DNS, to make sure the sugar is maintained above 200 mg per dl. Okay, I hope I'm clear in this. Okay, you have to continue the insulin until the acidosis is resolved. So how do you know the patient is, I mean, the acidosis is resolving and when to stop the insulin infusion? Okay, so there is a criteria to stop this insulin infusion. What is the criteria? Blood glucose should be less than 200 mg per dl. Serum bicarbonate level increases to 15 milliequiliters per liter, and the pH improves to more than 7.3. Okay, and an anion gap should be less than 12. Okay, so this is the point where you stop the insulin level, insulin infusion, and you convert to subcutaneous insulin. Okay, always make sure that when you are transiting the patient from uh, insulin infusion to subcutaneous dose or route, you always give a subcutaneous dose 1 or 2 hours before you stop the insulin infusion, so that it acts at on time. Okay, I hope this is clear. Resolution of decay, when to stop insulin. Blood glucose should be less than 200 mg per dl. Serum bicarbonate of more than 15 milliequiliters per liter, and venous pH of more than 7.3. Okay. When you are starting an insulin infusion, always make sure that your potassium is corrected. Why? Because insulin causes an intracellular shift of potassium, which will result in lower potassium concentration. So when you are starting an insulin infusion, and when you are seeing that the potassium is more than 5.2, you start the insulin infusion at a regular rate of 0.1 international unit per kg per hour. Okay, and repeat the potassium every 2 hours. Let's say if the potassium is between 3.3 and 5.2, okay, so what you do is you start the insulin infusion, but along with that, whichever fluid you are giving, let's say you are giving NS. So normal saline you are giving, for every 1 liter of normal saline, you add 20 to 30 milliequiliters of potassium. Okay. And if the potassium is less than 3.3, then what you do is you don't start the insulin infusion. You correct the potassium first, okay, at around 20 to 30 milliliters per liter until the potassium is 3.3, and then you start insulin infusion along with 20 to 30 milliliters of potassium in every liter of fluid. I hope this is clear to you. If the potassium is high, more than 5.2, you start a normal infusion. If the potassium is between 3.3 and 5.2, you start a normal insulin infusion along with 20 to 30 milliliters of potassium in every liter of fluid you give. If this potassium is less than 3.3, then you don't start insulin infusion. You first correct the potassium, and then once the potassium is 3.3, then you start insulin infusion along with the same 20 to 30 milliliters of potassium for every liter of fluid you give. I hope that is clear to you. Okay. Coming to the next point, when you are treating the patient in the ER, you always make sure you monitor few things very correctly. Okay. First is point of care testing of glucose. So every hour you test for glucose. If the sugar falls below 250, you start DNS and make sure that the sugars don't go below 200 mg per DL. Every 2 hourly, you start checking for electrolytes, especially potassium, because insulin tends to lower the potassium, serum potassium level in the body. Okay. Also, initial lab checking of complete blood counts, creatinine, very important, and blood urea nitrogen is very important because you might be missing something in the uh, in the other organs as well. Okay. Also, initially ABG and VBG monitoring as per your hospital protocol. So what we do is a patient comes to us with DK every hour for the first 3 hour, 3 to 4 hours. We do a VBG or an ABG to make sure that the acidosis is getting corrected or the bicarbonate is getting corrected accordingly. Okay. Apart from this, very important to have a cardiac monitor, ECG monitor, and saturation levels to be monitored continuously. And any deterioration requires an immediate intervention. Okay. Coming to the pitfalls. So we have seen why this, I have added this site because, whenever a patient comes to us in ER, and if the sugar is, let's say, 250, and some acidosis is there, we never think of decay. We always think that, the sugar has to be more than 300, 400 for a diagnosis of decay. So this delay in diagnosis makes us very difficult to treat such patients. So always, whenever there is an acidosis, whenever the blood sugar is above 200 or 250, make sure you do a ABG or a VBG and blood ketones or urine ketones to make sure that the patient doesn't have a DKA. Second thing is, whenever patient you diagnose a DKA patient, you start vigorously fluids, you start insulin and all that, and you don't work upon the precipitating factors, which is the most important in such kind of patients. Always get an ECG, always get an X-ray, always get an ultrasound abdomen or the CT if you are looking for an infection. Very important. Fluids, inadequate fluids. So we always try to, don't give fluid, and we try to rigorously start insulin from the start, which is not correct. Always restate the patient if the patient is hypotensive. Give good amount of normal saline as a in first hour, so that hydration is maintained, tissue perfusion is maintained. Okay. Whenever you are treating the patient with insulin, always check potassium level, especially serum electrolytes, especially potassium, every second hourly. If the potassium is falling below 3.3, stop the insulin, start correcting the potassium, and then restart the insulin. Okay. Uh, as we are starting the insulin, we overzealously start insulin according to the guidelines. And this is the time when we see a lot of patients going into hypoglycemia. Remember, our goal is not hypoglycemia or low glucose, our goal is to correct the ketones. Okay, so don't overzealously treat the glucose levels. Make sure the glucose is reduced at around 50 to 75 mg per dl per hour, not more than that. Okay. Every hourly, as I mentioned, electrolytes is very important. Yes, bicarbonate. So whenever a patient comes to us, we we see an ABG, and if the pH is 7, we think, oh my God, it is severe acidosis. We have to correct the acidosis first, and we give bicarbonate. Okay, bicarbonate decay is one of the very few uh, pathologies where bicarbonate is not recommended above 6.9 pH. Okay, because studies have found that you are not going to have any benefit of sodium bicarbonate in pH of 6.9. Even in low pH, it has only been found to have a cardioprotective mechanism. Nothing major beyond that. Okay, so if the patient is below 6.9, you start correcting with bicarbonate. Above 6.9, there is no role of bicarbonate in such kind of patient. Okay. Uh, Younger patient, especially pediatric age group, when you are overzealously treating with fluids, with insulin and all that, pediatric patient can go into cerebral edema, and frequent neurological checks are required, especially in pediatric age groups. The mechanism of cerebral edema is not very clear, but yes, one of the reason of cerebral edema is um, overhydration and insulin, which will cause cerebrum to swell up. Coming to the late complications of severe decay, one of the very common complication is refractive acidosis. It can be septic, it can be another reason. So last week we had one patient who came to us with kind of, some abdominal pain, some 3, 4 episodes of loose motion and slight restlessness. When we checked the sugars were around some 250 or 300. Ketones were positive. ABG showed acidosis with lactate of 8 and a bicarb of 12. So we thought it's a decay and we started treating like decay. But over 3, 4 hours, which we kept in ER and we repeated the ABG did not improve in spite of our restation. We have given some 4 liters in 2, 3 hours, 4 liters of saline. We gave insulin. We gave other supportive treatment. Patient didn't improve. The acidosis persistent. Lactates were persistently 8. And finally, we had to admit the patient in ICU. Okay. Later on, we came to know we have sent the infection workup and everything. Later on, we came to know that it was a metformin. Patient was diabetic and it was a metformin-induced lactic acidosis. This acidosis was refractory, was not getting corrected in the ER. Okay, so whenever there is a refractive acidosis, try finding out other causes of acidosis, like sepsis, like what I mentioned now. Okay, like ACS. Always look for other causes. Okay, cerebral edema, as I discussed. Mesenteric ischemia, yes. So we got a scan also done. It didn't look like a mesenteric ischemia at all. Uh, I mean, abdominal pain was not out of proportion pain. It was just, discomforting to the patient. It was not an out of proportion pain. So I have not seen many metformin-induced lactic acidosis. This was quite amazing, and we were all impressed that in spite of so much, we were not able to diagnose. And what happened is within 48 hours, patient automatically recovered without any treatment. Patient was just they were giving fluids, they were giving insulin. They were also ICU team also was thinking of decay because everything else came normal. Even the infection workup, there was some total counts, leukocytosis, but it was not. Blood cultures were normal, urine was normal, so they were not able to find out anything. And then one fine day, suddenly in the morning, she woke up as nothing has happened, and we all came to one conclusion that only drug induced can cause this because drug would have been flushed out of the body because of even patient didn't require dialysis as well. Okay, automatically the lactates improve after 48 hours. So it was interesting metformin-induced lactic acidosis. Okay. Um, Coming to the thrombosis, it is rare, but dehydration can cause vascular thrombosis in patients, especially if not corrected properly. ARDS, we all know that decay is kind of uh, you know uh, uh, activates this inflammatory or cytokine storm that can worsen an infection into ARDS. So always make sure that you keep on checking the lungs, keep on checking the IVC, keep on checking for any signs of ARDS or any signs of infection in the lungs. Mucormycosis is rare, but again, it's not very uncommon in diabetic patient. Diabetic patient tends to have low immunity. We all know that. And especially a patient who comes to us with headache, with a long-standing diabetic history, especially uncontrolled diabetic history, you have to think of mucormycosis because it's very common. Okay. So you have to get a scan done. MRI is enough actually to diagnose it. Especially after COVID, people are much aware about this. So I think we end here. Any doubts? We have covered hypoglycemia. We have covered severe decay. It's quite opposite of the spectrum. Any doubts? You can please tell me. Tell you.
Good evening, sir.
Yes, Mr.
Sir, how to titrate insulin according to glucose, insulin infusion?
So it's not about the glucose level. That's what I'm again and again telling you. It's not about the glucose level. It is about the ketones in the decay. Okay. So when a patient comes to you in ER, you start at 0.1 international unit per kg per hour. Okay. Once the sugar goes below 250, you reduce it to half. That is 0.05 international unit per kg per hour. So in a 60 kg young person, it comes to 0.1 international unit per kg per hour, comes to 6 ml of insulin per hour. Okay, which you reduce to 3 ml per hour once the sugar reaches 250. And this infusion you continue till your acidosis recover, your ketones recover, and your bicarbonate recovers.
Sir, what about if insulin, we are keeping insulin at 6, but the RBS is not decreasing?
What is not increasing? Sorry.
RBS is not decreasing. Like we have started, like we have glucose level of 400. We started insulin at 5, but even after 1 hour or 2 hours, the insulin level is, the RBS level is same at 400.
It's okay. You hydrate the patient, you continue the infusion levels, and you look for other precipitating factors.
Okay.
If it is a decay, it will not reduce within first hour. Don't worry. It will slowly reduce it. Don't worry. Okay. Uh, there is something called as hyperosmolar coma also, hyperglycemic osmolar coma also, where the sugars are extremely high, like it's roughly around 800, 600 above, okay, in which the mentation is affected, but the acidosis is not that much. One differential diagnosis of DKA is your HHS, but in that your bicarbonate level and your acid levels will not be as bad as you see in decay. Yeah, please tell me. Hello.
So, Dr. Kushal, there is a question in the chat box also.
Okay.
Dr. Usha has kept it.
Okay. How much substitution should be given when we switch? Okay. So it depends on the doctor treating. So how they calculate is they see the insulin level. So basically, they randomly give insulin on the first day. Once they are starting it, let's say the patient is already on insulin, then they will continue the same dose of insulin. Okay. But if the patient is not on insulin before, then they randomly start giving human ectropit subcutaneously. So what they will do is they will see the insulin required throughout 24 hours. So let's say they give 666. So it comes to around 666. So 18. Okay. So what they do is they give one third of that 18 international unit in the night as a long acting drug, that is Lispro. And the two-third, what the insulin, like let's say two-third is roughly how much? 10, 9. That comes to that they will divide it into two doses as a morning doses. So I'll tell you again. So let's say to maintain the sugar below 200, the patient required 24 international unit throughout the day. Okay, in sliding scale on first day. Okay, so 24 international unit throughout the day in sliding scale. Okay, so what they will do is the 24 they will divide into two-third and one-third. So one-third is around 8 and two-third is 16. So this 16 they will divide into two doses as morning and evening, or morning or afternoon, and the one-third dose that they will that is 8 international unit they will give in the night as a long acting before sleep in Lispro. Okay, and other two-third is a short acting drug they will give in the morning and afternoon. Am I clear? So, hyperglycemia, for example, 450 without any acidosis ketone. So, if it is symptomatic, if hyperglycemia, okay. Okay, if at all the patient is symptomatic and sugars are high, you can start an insulin infusion. There is no harm in it. But if it is not an acidosis or ketones, you can correct it with sub-Q or fluid also. It depends on patient to patient. If it is high and patient is symptomatic, patient has come to us with sepsis, it is better to keep a strict glycemic control in kind of septic patients with insulin infusion. We should give bicarbonate patients DK with pH. Should we give bicarbonate patient of CKD? Yeah, so CKD patients are a bit tricky. What they tell is generally they don't give bicarb till 6.9, but let's say if bicarb is 6, you can consider it giving, but it is not going to help you in treatment of DK or acidosis. It is just CKD patients tends to have low bicarb. I don't think so it will cause uh, um, it will cause any huge difference. But yes, bicarb is 6, then definitely you can consider in a CKD patient. But remember, in a CKD patient, if the patient is on dialysis and on fluid restriction, giving bicarb can cause fluid overload. Okay, so in that case, you might uh, consider the general dynamics of the patient and then give bicarb. Not increase. You have to keep it 0.1 international unit per kg only until it is. So I didn't get your point. So after reducing it increases like that. So after reducing the sugar, it again increases. That is, then you want to increase it, is it? I didn't get your question right.
Sir, good evening, sir.
Yeah.
Sir, if the blood sugar levels early during early CBG monitoring, if the blood sugar levels are the same and it is high, can we increase it a little, sir? Because we have been doing like every hour CBG we used to monitor, and And in 500 ml NS, we used to administer 50 units of rapid insulin, and then we increase it from 50 ml per hour to 75 ml per hour. We do it like that, sir. Is it the right practice, sir?
So you give insulin in 500 ml, is it?
Sir, infusion pump also we use, or if the infusion pump isn't available, we used to administer it like that as an infusion in the NS, sir.
Okay, so how much per ml it will come?
Sir, 5 units per hour, like that. If we have administered 50 units of insulin in 500 ml NS at 50 ml per hour, it will give insulin at 5 units, sir, for a 50 kg.
That is correct way to give.
If
No
the
problem.
hyperglycemia is resistant, and if the early CBG does not reduce satisfactorily, we used to increase the rate to some 75 ml per hour. We do like that, sir. Can we do like
Yeah,
that?
so it depends on your hospital protocol. What they
Okay,
say
sir.
is the sugar level should not fall from above 50 to 100 mg per dl per hour.
Per hour. Okay, sir.
Yeah, your goal is to reduce sugars by
Only
50 to
100. Okay, sir.
75 mg per dl per hour. So however
Okay,
you
sir.
do it, it doesn't matter. But guidelines says that point international unit uh, is an ideal way to start. But again, if it is not reducing, you can increase it. No problem.
Okay, sir. Thank you, sir.
Yeah.
So
Anybody else?
I just thought one question, which is recent advances according to me, 2023, about subcutaneous insulin protocol in mild to moderate decay.
Yes,
So
ma'am.
probably squid protocol people have talked about, and any update on that? Or because what I always used to feel was that severe decays are very hemodynamically unstable as well. So the absorption of subcutaneous insulin may not be good at that point of time. So any update on this, though it is mild to moderate and not the severe decays, which was the spectrum requirement. But
Yeah, madam. I vaguely remember squid. Uh, subcutaneous insulin is in mild is practiced, especially with the newer insulin analogs that have been found. They are used, but I don't exactly remember what was there, ma'am, in squid.
yes, even I was just wondering, but
Yeah.
that normally we are not using it in very common practice, but mild, please do not write them for severe decay, neither do answer. It is only for mild to moderate decay, and there are meta-analyses which are already posted, which have shown what are the fallacies of that treatment. So students can refer it for the meta-analysis for subcutaneous insulin in MTM, that is mild to moderate decay. So because that was not part of this talks, but sometimes can be asked in exams. So please do not fall in the trap of answering subcutaneous insulin protocol for severe decay. It is only
Yes.
for mild to moderate decay.
Yes.
Actually, that
And
is
it is usually seen in non-ICU setups where they don't have to monitor that frequently. That was a squid protocol. Actually, they compared with ICU and non-ICU patients with the same sugars and same level with squid. That is what I vaguely remember it. I don't remember it.
Yes, very correct, Dr. Kushal. Rather, after that, some 170, because one of my PGs was, I was also interested and I was talking with someone among our colleagues. So 176 patients, we read that someone has done in emergency department as well. But again, the focus was on mild decay. The focus
Okay.
was on not sick patients. So that is very important. So sometimes what happens is that we do not read the entire study and just see that, oh, there is a subcutaneous insulin protocol, and tend to apply it not in the correct population. Then
Correct,
it
madam.
be wrong. So just for those who are exam going, please be careful that this is not a protocol for severe decay.
Yeah,
That
it came in 2022, if I'm not wrong, very early.
Yes,
Yeah,
22, and then very soon, means normally any new protocols and new studies, interventions, they get their meta-analysis and all that done after 3, 4 years. That is
correct.
how I've seen it. But probably after COVID-19, everyone wants to do fast meta-analysis. So this one, the meta-analysis was done with 256 patients, and as I was just while you were talking and discussing, I was just reading observational studies and a meta-analysis was been done. RCT was only two. So
Correct, correct.
so
Yes,
that doesn't really focus on the kind of pressure patient uh, population of diabetes India has. So please don't mention that in exam paper, because very important, because DKA can be one of the OSCE question. So sometimes in flow of writing in that 4 minutes, you tend to mention something like this. So please be careful on this. That is why I thought I'll add it up.
yeah,
That's
and they use short acting newer analogs actually.
yes,
Correct. Yes,
yes.
yes, ma'am. Yes.
Yes. So, for all students, it is important to read it up, because at mild to moderate decay, it can be asked. But do not try to mix it with if the question is on severe decay. So, recognize the OSCE first. What are they trying to put it? And then answer it. If they are asking, and you know how to differentiate between mild, moderate, and severe by now. So, just understand that and then further go into the question. That's it. So thank you. Thank you
Sure.
so much,
Thank you.
Dr. Vishal.
Thank you,
Uh,
ma'am. Thank you.
Always a pleasure to host you and have
Sure,
you
ma'am.
as a speaker. And I have means I'm sure that it is always at a very short notice I connect with you, and you have never said no. So I feel so
Yes.
equally proud and thankful to you. Uh,
Thank you. Thank you very much. It's all my pleasure, ma'am.
Yeah, wish you all again a very happy new year. I also have one more announcement, and that is Dr. Kushal only, along with one of two of my other colleagues, are doing board reviews for one day in emergency medicine, and that is on 19th of February, which is probably after the OSCE exams for dispatch. But for next batch, it is all preparations for how to do OSCEs. So those who are interested should come. The practical exam date has shifted from last week of January to first week of February. That is all I can tell at this moment. And Dr. Kushal, I think so. We will disclose as you will update us on topics. We
Sure, ma'am.
will
Sure.
the topics as well to the
Yes, ma'am.
students, because there are
Sure.
many students who would love to attend one day of board reviews, because board reviews is the way to go forward to collect all the recent information, all the practical information on certain topics.
Correct,
That's
ma'am. Sure.
yeah. So thank you everyone.
Thank you.
Have
Thank you very much.